And hello, everyone. We are live streaming on Facebook, and this event is also taking place on Zoom. As I admit, a few more people that are in the waiting room. I'd like to thank everyone for joining us this evening. The Novi Public Library, along with Ascension Providence Hospital and the American Cancer Society, for this very special program for the health of it, as we talk about breast cancer prevention and detection. It's my very special pleasure to have guests joining us this evening. We have Dr. Khawajawala. She gave me permission to call her Dr. K, and also Dr. Singh, who they are both here representing Ascension Providence Hospital. They are the experts. They know it all. Save your questions. We will jump in here and there and address your questions. If you are watching us from Facebook Live, feel free to type your questions in the comment section. I am monitoring it there. If you are watching us through Zoom, you can type your questions once again through the chat section, or you can actually open up your mic and ask your question yourself. That's also welcome. But I'm pleased to have my guest here. Welcome and thank you so very much. We're going to start with a little brief introduction. I figure the people can introduce themselves much better than I can, huh? So welcome, Dr. Singh. We'll start off with you with a brief greeting.
Hi, how are you? Happy October. Welcome to Breast Cancer Awareness Month. I'm Dr. Singh. I am the Section Director of Breast Imaging at Ascension Providence Hospital, which many of you in Novi know is right on Grand River and Beck Road. And I'm a radiologist, so I see all your mammograms and know you guys by how your breasts look on screen.
Very good, thank you. And Dr. K.
Thank you for joining in today. So I'm Nafisa Khawajawala. That's my working name. And I'm the medical director and a breast surgeon for the Ascension Providence Hospital systems. And I hope you don't ever need me, but I would be the one who would be operating on you should you have an abnormal mammogram after a biopsy or should you need surgery. And also then follow you through your survivorship plans and help you plan out your individualized breast cancer treatment.
Thank you very much. Well, everyone, this is going to be a really interactive type of program. You're going to be filled with a lot of information that you can carry with you, share with a friend or loved one, but also you're going to have a chance to test your skills and knowledge. We're going to have a little survey is what we're going to do. For those of you who are on Zoom, you can participate in this, and we please encourage you to do so because there was a chance for a prize later on. We're going to talk about that, but I'm going to open up right now and I hope this works. I've never done this on Zoom before, but there's a poll. Let me know if you can see it. I am launching it right now, just a short 3-question survey to see how much you know. Tell me, nod of head, Gail, do you see it? Okay, very good. So just 3 short questions. I'll give you a second to complete them, and then we will take this exact same survey at the end of the program just to see how much you're paying attention. As people are taking the survey, I'd like to introduce Gail Blakely. She is the programming coordinator for Ascension Providence Hospital. For this particular segment, we're going to talk about what someone can win toward the end of the program. Talk a little bit about that, Gail. Welcome.
Thank you, Gail. So we ask that you participate in the pre and post test. So at the end of the program, we will offer the same questions just to kind of test your knowledge. And we'll have like a spinning wheel. This is new for me as well. You can win this. This is for Awareness Month. If you win, you can get a $25 gift card, Visa gift card. So I hope everyone participates in the pre and post test. And then once we get our winner, this will be coming in the mail to you. Thank you.
See, I see the participation percentage just upped by 50% when you said that, Gail.
Nafisa and I will not be participating in the poll.
Correct.
No cheating on our end.
All right, we're going to end the poll. I'm sorry, we're going to end the polling in just about another 30 seconds. I see a few people still participating. If you're watching on Facebook, you have no idea what's going on, but next time, so you can log in and register through our Zoom, and then you can take part as well. But we welcome you to watch whatever platform that you're on. All right, we are going to end the polling right now. And we'd like to get our program started. We're going to get started first with Dr. Singh. She has a presentation for us. We look forward to hearing from you, and we will jump in probably maybe about 5 minutes or so with questions and answers. Welcome, Dr. Singh. You can take it from there.
Okay, let's try to share this and get this going. Okay. So as you mentioned, I mentioned earlier, I'm a radiologist at Ascension Providence, and I just really wanted to talk to you guys about how to love yourself and love your breasts and take care of yourself to the best of your ability in this particular part of your health. Just a little PR for radiologists. Most people don't know what that even means and who really looks at your mammogram, but every mammogram that's taken is reviewed by a radiologist pretty much in the United States. We went to medical school, we're physicians, we did a 5-year residency in radiology, and then most of us, or many of us, did a 1-year subspecialty fellowship and specifically breast. So it took a lot of training to look at that mammogram, so we take it very seriously. Every person is looked at the utmost care to make sure that we find the cancers when needed. I just want to talk a little bit about your lifetime risk of breast cancer. As you know, it's about 1 in 8 women. This is all over the news, all over TV, and we all know someone who's been affected with breast cancer because it is so common. So why the big fuss for breast cancer over other cancers? Mainly because we can actually make a big difference with breast cancer as compared to many other cancers. If we find it early, we can get rid of it. We can really kind of cure it to the best sense of the word that we have today in 2021. And hopefully you can live a very normal life once that breast cancer is removed and the treatments that we have available are offered. Unlike some other cancers such as ovarian or brain cancers, where even if we find them, we just don't have the ability to really help those patients have a normal life in many cases. So what exactly increases your risk of getting breast cancer? There's a lot we don't know, but the things that we do know is that main thing is just age. As we get older, the cells in our body kind of start to turn over. And as we get older, our risk of breast cancer is just going to go up. That's the #1 thing that's going to increase your risk. And we can't change the aging process. Other things like family history, really only about 25% of patients with breast cancer have a family history of breast cancer. This is often a big misconception amongst women. They come to me and say, well, I never had it. No one in my family has breast cancer, so I don't need a mammogram every year. And that's really just not the case. High breast density, also a big hot topic, does increase your risk a little bit, but not quite as much as some of the other variables. As we all know about the BRCA1 and BRCA2 genes with Angelina Jolie and some other celebrities that have been in the media. But there are other genes that we do have that we are aware of now that do increase your risk of breast cancer that we can test for. And then things like longstanding hormone therapy, estrogens, progestins, things with hormone replacement therapy, and then also patients who've had chest radiation from things like lymphoma and very, very long ago, like acne treatments and scoliosis treatments, which we really don't see in patients today, but did occur in the early 1900s. On the internet, you can read things like caffeine, parabens, alcohol, deodorant, soy, underwire bras as being causes of breast cancer. There's really no evidence to support any of these things, but you know, if you're able to kind of decrease some of these exposures, they may help your long-term risk. We really just don't have the evidence to support that, but I personally do try to cut back on things that I can, just because, you know, we all try to live a healthier life as long as we can. What can you do to reduce your risk that we know has evidence base? You can watch your weight. That produces estrogen, and as we discussed, that estrogen prolonged state is what can increase your risk of breast cancer. Exercise, if you can walk about 75 to 150 minutes per week, and then limit that alcohol intake to about 1 drink per day, and avoid or limit hormone therapy when possible. Okay, so early detection, there's already a cure as long as we can find that cancer early. A cancer smaller than the size of an apricot has about a chance of 85% chance of survival, which is huge. So if we can find those cancers very small, which typically is only really detectable by imaging, then usually you're going to have a relatively normal life once you've gone through your surgery and any sort of other therapy, depending on the tumor size and kind of tumor that it is. Once you can kind of feel a tumor, most of those patients are, stage 2 or beyond. And so we really don't want to wait for cancers to be palpable before we start treating them. So are there any questions about any of the risk factors or anything that we've already discussed regarding kind of reducing your risk or why we need to detect cancers early? Okay,
If you do have questions, please type them in the chat. Or
okay, I'm just going to
pose them for you.
I can keep going then, I guess. Just a quick review of stages of breast cancer, because I know a lot of patients will come in and say, oh, she had stage 0 or stage 4. What does that mean? So stage 0 really is what we talk about when we talk about ductal carcinoma in situ, or DCIS. You may have had a friend or a family member who told you they had this type of tumor. And this is essentially 100% survival rate. These are very easily treated. Stage 1, very small, often what we find with mammograms. So 98% survival rate. It hasn't spread to the lymph nodes. It hasn't gone anywhere else. And then stage 2 and 3 kind of are where the tumor's a little bit bigger. We've got them into the lymph nodes. The survival rate starts to decrease in those areas. And then stage 4 is the kind that we don't want to see at all, but where the cancer has already spread to other parts of the body, and the survival rate does go down with that. So just a quick review, because I know a lot of patients ask me that question all the time. How do you find that cancer early? Again, annual mammogram at the age of 40. These have reduced the number of cancer deaths by about 1/3 over the last, several decades. The self-exam once a month, we still recommend as radiologists. I know there's some different clinicians that have different thoughts about that, but I really do believe that you know yourself best. And we have lots of patients who come in who say, something is just not right. I feel a change. And that is the way that we detect their breast cancer early. So I'm a proponent of doing that. And then a clinical breast exam by your OB/GYN, your primary care doctor, your internist, whoever you may see, is still really important. They do a great job at feeling abnormalities. In the news, there's all kinds of controversy about when to start that mammogram. So I'm a radiologist. I recommend age 40 and then get it every year. It's a very simple test. It's a little uncomfortable, but it's a very minimally invasive thing that we do relative to a lot of things in healthcare. It's relatively cheap, and it does save lives. There are other, discussions going on about whether or not it's worth the cost to society to get it every year at age 40 or every 2 years or start at age 50. But what you need to know is that despite all the data, the most important thing is the most lives are saved if you start at age 40 and you get it every year. When to stop that mammogram, when is too old, really is a tough thing to say to people as well, because many people have very high functional status in their 70s and in their 80s. And if you're going to live another 20 years, breast cancer could reduce that lifespan. So that's really a discussion that you need to have with your doctor, probably at the age of 74, 75, about your own health and where you stand in that, and whether or not you want to continue to get mammograms every year. I have patients in their late 90s who come in and they just, it's part of something that they do for themselves, and it's part of their routine, and they're not going to give it up, and they don't need to. So it is really a discussion to have with your doctor, but just know that there is a lot of controversy. So it's not such an easy thing as to say, stop on this day and start on this day. 40 every year, if you ask most doctors, is what they do for themselves. That's what I do. That's probably what Nafisa does. That's what we recommend to all the people in our department. So it seems to be kind of the best case to find cancers early and prevent the most long-term effects of having them. Any questions about any of that? Okay.
We're good.
All right. So it might be a little blurry. I'm sorry about that, but just some need to know numbers that help justify why you really need to get that mammogram at 40. So 1 in 6 of all breast cancers occur in women in their 40s. So it's not like women don't get breast cancer in their 30s and 40s. In fact, we're seeing that number of people actually go up. And why that's going up, there's probably a million causes we can't even begin to understand, but environmental, diet, stress, all kinds of stuff that's happening, but it is going up in what we're seeing. Even for 50+ women, skipping a year between mammograms could result in about 30% of cancers being missed. So that's a significant number to consider. Remember that three-quarters of breast cancer patients have no family history and are not considered high risk by the models. So looking at just your risk does not necessarily predict your chances of getting a breast cancer, because we know that that's a very small percentage. And then there's also, remember that, when you get a mammogram, while there's a chance that you're going to get called back and you're going to need a biopsy, these are relatively small numbers. So for every 1,000 women that we do, about 100 were called back. Now that we have 3D mammograms, that number's come down to about 80. So for every 100 women, about 80 are called back, or sorry, every 1,000 women, about 80 are called back for more tests. 20 of those 80 will get a needle biopsy, and 5 will be diagnosed with breast cancer. So there's a lot of talk about anxiety with getting your mammogram and anxiety of getting that call back, and it's very stressful. And while I completely understand that, I mean, I consider myself, like, I would be so stressed out if someone told me I had to undergo a biopsy, because we know what's on the other side of this. But at the same point, it's for your own health, and it's the reason you're coming in to get that mammogram. And we know a lot of these things are going to be benign, but we have no other way of really knowing for sure without a biopsy in some cases. And the stress of getting a breast cancer diagnosis, if you waited on something or didn't get a mammogram or didn't follow up on the lump that you felt in your breast, is far worse than the stress of getting a call back and being told that something is okay. I've seen patients have so much regret about this, and all we can say is that just take care of yourself first. Women are the first people to take care of everybody else and ignore their own health. And we're the last ones to go in to take care of ourselves, but we're also often the most important people in the household. If the mother or the woman is not able to take care of herself, everyone else is going to start to fall apart. So get that mammogram. If you get called back, just try to remind yourself that most of the patients who get called back, including myself, if I get called back, it's going to be fine. It's not going to be anything. And even if it's something and it's been found on your mammogram, it's very, very likely that it's going to be very treatable and you're going to live a normal life and a healthy life. So it's just part of what we have to do to take care of ourselves. Another little schematic about this, but remember that 1 in 69 people, or women rather, will be diagnosed with invasive breast cancer in their 40s. So 40s is an important number. So that's why we really don't want to wait until 50 to get a mammogram, because you're going to cut out a lot of those patients that being detected. All right. Any questions about that? Okay. Any patients out there that have anxiety or questions about, things that could be anxious producing for a mammogram, or questions about mammogram specifically? I'm going to talk about it a little bit, but just kind of think about those things. Like, what makes you nervous about getting your mammogram that I can maybe alleviate for you to make it easier for you to come into your next appointment? So what is the mammogram and why does it hurt? Well, most of you have had it. This is what it looks like. If you haven't had one, this is what you're going to undergo at some point. Every woman is different. Not every woman has the same amount of pain. Some women are very sensitive, and some women just don't feel anything when the mammogram is done. So you really don't know what your own experience is going to be like until you go in there. So really try not to Google the worst case scenario. Just try to come in with a positive mindset that it's going to be okay. It's pretty short. Really what it is an X-ray, just like a chest X-ray, but we take it up the breast in multiple projections. We use compression. We have to use compression in order to spread the tissue out so that we can see the areas of abnormality. And, a lot of people get worried about the compression, but know that the more we compress the tissue, the better the images, the more likely we're going to find something. And also your radiation dose is less. So if you're worried about the radiation, you really want your breast to be compressed as much as possible, because we don't have to use as much to be able to see all the tissue. And also know that your breast tissue really, goes all the way up into your armpit, all the way up here. That's a lot of people get masses here and kind of miss cancers in this area. So we really have to do a good job of getting that onto the mammogram. And that's kind of why it's a little bit uncomfortable, but this is something that's very important to image. The dose of a mammogram, people always worry about this. You can see here on this little schematic, is very low when you just compare even what you get from being a United States citizen and just being exposed to what's in the ground and what's on the sun. I tell patients that, kind of getting a mammogram is thinking of yourself flying from New York to LA and back. That's how much radiation you're going to get just being on the plane. So it is radiation, and we don't want to use it without considering the side effects, and we don't want it to be a high dose. We do everything we can to keep the dose as low as possible, but just know that by being Americans, we're exposed to radiation all the time. We're not even aware of it, and it's really not that much. A mammogram is actually less than what we would get every year by just being in this country. Just some examples of what a mammogram looks like and some cancers. So on the far left side, there's a palpable white mass there. That was a cancer. In the middle image, closer to the bottom of the screen, there's a little white spiculated mass there. It looks like a little tiny cloud. That was a small cancer. And on the far right image, these are what we call calcium deposits. And this is what we would call the patient back for to get these magnification images, which show those calcium deposits better, that we can help characterize them and decide if they need to be biopsied or not. And so when you get that call that says you need to come back, we need to do additional pictures, that's what we're trying to do. We're trying to spread things out, take a better look at things, get a better idea of things, and really decide if this person needs a biopsy. Can we just keep an eye on things because it's probably nothing, or can we just say it's totally normal and we'll see you next year? And so in this case, this was a cancer and we did have to do a biopsy, but it was very early stage and easily managed. So any questions? I'm going to go real quick. I'll go over the mammogram tip stuff and then we can talk about mammograms if there's any questions. But tips for the day of your mammogram, October through December are the busiest months. So if you can schedule for January and March, you'll be getting in without an issue for your appointment. If you try not to schedule your mammogram right before a vacation or trip, just because if you do have to come back in, you don't want that anxiety ruining your vacation or your trip when it may be nothing. So, it's always the worst when a patient's like, I got the mammogram and then, oh, I'm going to Florida on Friday for a month. And now what do? I feel nervous, so I cancel my trip. Can you get me in tomorrow? And it's a bad situation because we don't have a lot of appointments if we're busy. And also we don't want you to be anxious for the month, even though it might be nothing. So just kind of consider that. The best time to come in is week 2 of your menstrual cycle. So if the week that you bleed is considered week 1, and then week 2 is right after that. And that's to help reduce any sensitivity to the breast and also kind of the hormonal fluctuations that can cause your mammogram to have what we call more false positives or more likely to have to come back. Some patients take ibuprofen before they come in about 30 minutes before. We have no issue with that. Remember to wear a top and pants rather than a dress, so that way you can keep your pants on and just remove your top. We do give you a gown, but it's always a little awkward when someone's in a dress and then they feel like they have to kind of cover up with 2 gowns. It's just easier with pants. Any necklaces below the collarbone will be removed. And then we always remind this during the call, but no deodorant or special lotions. You want to wash your armpits as well as you can before the appointment to remove any residue. And this is because this can cause little calcium deposits to show up on the breast tissue. And then we would have to call you back to make sure that they weren't actually in the breast, because those could be, again, an indicator of cancer. So we don't like to see those little flecks of deodorant on the skin. You want to come about 15 minutes early because there's going to be forms to fill out. If you have any outside priors, so let's say you went to, another institution, another hospital last year, now your insurance has changed or you've moved. If you can bring that with you, we can upload it into the system that day and have it for comparison that day. So we don't have to wait on giving you a report. And also it'll be less likely that you would have to come back for any additional pictures because we have a comparison. So just kind of keep that in mind. And then give your tech a heads up about any neck or shoulder pain that you might have, because they're going to try to do everything they can to be as sensitive as they can for you and with you while getting the best pictures that they're able to. So give them a heads up so they don't do anything that would make you uncomfortable. And then just remember, each picture takes only a few seconds in compression, like less than 30. So just be patient. It'll be over soon. And you've done something good for yourself for the year. Mammogram questions.
I do have a couple questions that are in the chat right now, if we can take them, Dr. Singh. One is, how long does it take for the symptoms to show up and be identified in the mammogram?
Meaning like for a cancer to develop and be identified? I'm guessing is what
that's what it looks like they're meaning.
Okay.
Yes.
So we can detect cancers as small as 3 millimeters, 1 millimeter, 2 millimeter. I mean, it depends on the density of your breast, if you've had prior studies, how much has changed, but we are able to see and biopsy cancers as small as 2 millimeters, 1 millimeter, very, very, very tiny things. I would say more often cancers are kind of detected at about the 1 centimeter mark, between 5 millimeters and 1.5 centimeters. So you're talking about half an inch, but we can see cancers that are probably like 1/8 of an inch is better if you're not thinking about millimeters, but very, very small.
I can add a little bit to it. So, if you look at molecular studies whereby cancer was induced in rats and mice, we really don't know the exact the time which goes by till the cancer develops and shows on your mammogram, because it depends on a lot on the biology of the tumor. If it's one of kind of the cancer, which I call with the good characteristics, it's like estrogen positive, then that has a very, very slow growing effect and probably has been there for maybe a year or 2 if it is a centimeter. And sometimes patients will not do a mammogram and show up with these large masses in their breast, asking them, oh, I had this lump for 5 years. So depending on your tumor biology, that answer is very, very variable.
Okay.
Correct. Yeah.
It sounds like you're answering both of these questions. One is the how long does it take for the symptoms to be identified? And then the next question is, I have been told I have dense breast. Why is that a concern? So maybe you can touch on that specifically.
Yep, we have like a whole little lot about dense breasts, but very, very quickly, dense breasts are a concern because one, they may make it harder to feel the cancer. Two, they make the mammogram harder to see because the cancer is white and dense breast tissue is white. So it hides the cancer. And three, there are studies that have shown that having dense breasts can increase your risk of breast cancer. And this probably has to do something with the fact that you have more glandular tissue in the breast, which is the more hormonally active tissue. And as a result, there's more turnover of the cells, which then gives you more opportunity for cancer to form. So those are probably the three causes. It's not as high of a risk factor as people thought it was maybe at one time, but they're still kind of studying exactly how much it's going to be. And there's nothing you can do to change the density of your breast. People always ask, like, well, what can I do? It's just the way you're made, you know, it's like your skin color. There's really just, you have to embrace it. It's not a bad thing. It's not a good thing. It's just the way you're made. And we do the best that we can with how we are.
So again, to add on to it, it's, on a population level, it will add maybe 1%. I mean, your smoking history can add maybe a lot more. High alcohol intake can add a lot more. But like Dr. Singh said, there's nothing to be changed about it. You just have to be diligent on the time that you do your mammograms. And it's just who we are, and
I have
you
a
see that
question.
some
So
women
if a
have
patient
fatty
has
breasts.
dense breasts and say their mother or sister first line was diagnosed with breast cancer, is there any other screening that your patient should maybe have outside of just the mammogram? Should the 3D mammogram, should they do a ultrasound or MRI or?
So that is something which we would assess as an estimate of your risk. We would run these risk models in the clinic, or sometimes with even Dr. Singh in there, they would have your family history taken. So that adds up the two things you would say, that it's a family history and you have dense breast, which is mentioned prior on your mammogram. So that will increase your risk from the 1 in 8 to maybe a 1 in 7.5. It's a risk model we run, and I won't be able to, answer any more than that. And depending on your risk being higher, yes, we will add maybe an additional screening test for you, depending on what is needed. So
Yeah,
I want to ask us,
yeah,
I'm sorry.
Just to add to that. So ultrasound in a dense breast patient can be done as what we call supplemental screening if you have average risk. So if you do that model and you kind of look at your family history, when you started your menstrual cycle, how many kids you have, there's a whole list of factors that are put into that model. And it says you are of average risk to get breast cancer, so you're close to that 1 in 8 line, then supplemental screening with ultrasound can be done. It's not required, it's not enforced, but it can be discussed with your primary care doctor. But if you're high risk, so you have usually, 2 first-degree relatives that have had breast cancer in your family, like your mom or your sister, or very young people in your family who've had cancer, like people have had breast cancer in their 30s, or someone with ovarian cancer, that makes that risk factor go up over 20%. Then we would not recommend that you get the ultrasound. We would say you're just better off getting the mammogram and the breast MRI, because breast MRI really is the most sensitive thing we have for breast cancer. And the studies that have been done show not enough of a benefit from the ultrasound, and really a great benefit from the MRI. So that's where someone like seeing Dr. K, if you have family history, is helpful, because they can help navigate this process with you for your own personal risk about what exactly you need to do to screen yourself for breast cancer beyond just a mammogram.
So
Very good, thank you.
Yeah, and another question was, is the density due to fat? So
Yes.
actually, the answer is no. The density is because of the glandular tissue. If you have more fat in the breast, that's actually better. So that becomes a scattered fibroglandular or a fatty breast. I think Dr. Singh will probably go into it, but the density is not because of fat.
Thanks for getting that for me, Dr. K. We're going to let you, Dr. Singh, continue with your presentation. If you have questions, continue to type them in the chat, and we will pause again later in the program to address your questions. Dr. Singh.
Yeah, perfect. So 3D mammograms, we have them pretty much have become, they're not the standard of care, like it's not required, but almost every facility in this area, the Detroit metropolitan area, offers 3D mammogram. And just to keep it simple, it's more pictures. So it gives us a better assessment to look for the breast cancer. It is helping us find cancer smaller, as well as calling back less patients unnecessarily for those false positive callbacks. So like I mentioned before, we used to say about 100 and 1,000 would be called back. And now this has dropped down to about 80 and 1,000. And we're definitely finding, cancers that we weren't able to see in previous years with the 2D mammogram. So if you have the opportunity to get a 3D mammogram, don't hesitate. It's the better test. It's the right thing to do. Almost every insurance covers it now. So there really should be no reason to get the 2D. Just an example of what a 3D mammogram machine would look like. So instead of just taking 2 square pictures, it takes an arc of pictures, and that arc we can view kind of like a video to kind of look at the breasts in a much better and very much more helpful way. Here's an example of what that 3D go ahead.
Just to add is it's like a squishing an apple. So if you squish it down, you will miss the seeds. But if you arc over the apple, like slice it down, then you will still see the seeds. Is kind of the difference between the 2D and the 3D for me.
Yeah, that's a good analogy. So just an example of far left of the screen is what a 2D mammogram would look like. We would just get that one picture. Now with a 3D, we get a whole set of pictures, and you can see on these like slices, as we get closer to that number 43 in the middle, you can really see that cancer pop out. This is the same patient. We wouldn't maybe not have seen that cancer on the 2D mammogram if there hadn't been a change. So I had nothing to do with Hologic. They're just a company that provided images, but I have to keep their name on there because they're pictures. So it really, this is what we see in real life, but I didn't want to use their actual patient. So this is like a commercial patient that they have. It's very, very helpful. It's the better test. Another example, on the left side of the screen, we have the 2D version of the same patient, and on the right side, the 3D. So you can see how that cancer, even without being a radiologist like me, that cancer is much easier to see on that right image than the left image. And that's really what we want. Can I get mammograms if I have an implant? Absolutely. We do what's called implant displaced views. We kind of help push the implant back a little bit and are able to get the remaining breast tissue into the mammogram. And, patients are always worried about their implant, but we do tons of patients with implants, and it is extremely rare to ever have an issue with the implant after the mammogram. I mean, nothing's 100%, so I can't say it's never happened. It's never happened in my experience, but I'm sure someone out there has had an issue, but it is extremely rare. It's not something you should worry about. We have protocols, and it's still the best test for patients with implants to detect any sort of cancer. Oops. Let's go back. Okay.
Yeah, and you can almost really compress an implant, or when people get it in the office, and you can compress it, and it does not burst, it does not tear. So it is, very simple to get the mammogram with implants in.
To touch a little bit on whole breast ultrasound screening, which is someone had asked about, this is best in patients with dense breasts that have average risk, like I mentioned. There's not going to be any radiation associated. And the studies have shown that you can find an additional 3 per 1,000 cancers. But this also finds a lot of benign things. For those of you who've had an ultrasound, you might know, oh, I have some cysts or I have some benign masses. There's a lot of stuff in the breast that are just there naturally. Like I tell patients, it's like having moles or freckles on your skin, which you can see, but you have moles and freckles, so you don't worry about them. They're there, everyone else has them. But inside you don't know what you have until we start looking and we start taking pictures of things. So when we do the ultrasound and we find these little benign masses or these cysts, some of them may meet criteria for follow-up just because some cancers can also look like that. So we get stuck putting these patients into either biopsies or following them up. And so that's where kind of the benefit and the risk to getting the ultrasound is there, just like mammogram, but it's a little bit higher, that you're going to have more benign things that are found that are going to require follow-up and or biopsy. And not all insurances are going to cover breast ultrasound for screening. So that's something else that has limited patients, at least in our area. It's a state-by-state situation right now. And so something you can discuss with your doctor if you have average risk, meaning you're just like a normal person that has an average breast cancer risk. Fibrocystic breast tissue, a lot of people say, they come in and they say, I have fibrocystic breast tissue. Again, it's not a bad thing. It's normal. It's not pathology. It's not anything. It's not a disease state. It is a normal way that you are made. So just an example of a picture on the left is what your normal fat, which is yellow on the picture. The pink in the middle is your glandular tissue. You can see the nipple there. And so if you have fibrocystic tissue, you might have more of that fibrous tissue, but a lot of little microcysts and macrocysts. So small and big cysts kind of intervening in there. This can give you a lumpy, bumpy feeling. This can make you feel like some of these cysts get larger and smaller with your cycle. These people can have more breast pain with their cycle. And often these people do end up getting more biopsies and more procedures done because they have more symptoms and more reasons to come in. But it's not bad to be fibrocystic. And again, not really much you can do about it. It's just the way that you're made. Dr. K can maybe talk about some things that have been anecdotally there to help patients with breast pain and such. But you know, that's what fibrocystic really means. Dense breast, as you mentioned, someone had asked a question. So on the left, we have what a mammogram would look like for a dense breast, which is pretty much whited out as compared to the right side, which is more black. And the black just is the fat on the x-ray, and the white is the glandular tissue on the x-ray. So we can really pick up cancers pretty easily in a patient that has a fatty breast as compared to someone who has a dense breast where the cancer is very easily obscured by that white tissue. Okay, so we've talked about, just to give another example, these are the 4 categories of density that you will see in your report when you get your mammogram. You're going to get a letter that's sent to us, sent to you required by law, that's called a lay letter. And that letter basically just says your mammogram is normal, your mammogram has some benign findings, your mammogram has something that requires a follow-up, or your mammogram has something that requires a biopsy. And we're required to send you that letter by law. We're also required to tell you whether or not you have dense breasts. So if you have dense breasts, it now is in that letter. It's going to say you have, you know, I actually have the actual verbiage here. I can show it to you. I'll show you the exact verbiage, but it basically says you have dense breasts, and so you should discuss with your primary doctor possibility of getting an additional ultrasound and or MRI depending on your risk. And this is required by law in the state of Michigan, so don't hate us for putting it in there. It is legal. So don't be concerned when you see that. It's just a little flag that this has been reported on your breast density, and you have a right to know about it so that you can discuss with your doctor what you should do about it, if anything.
Hey, Dr. Singh,
Yep. Mm-hmm.
just real quick about that. So it's up to the patient to talk to their primary care physician. It's not something that's sent to the primary care physician in the report.
No, the primary care physician is also, any doctor who sends you in for their mammogram or anyone who looks at the report is also notified of your breast density. And that has always been the case since mammography has been, since like 1992, I want to say, or 1988 or something like that. We have always reported your breast density to your physician, but it was not, the patients were not notified. And there was basically legal issues in Connecticut that the patients basically brought it to the state that they were concerned because they weren't aware that they had this limitation and or this risk, even if their doctor knew. And so now it has become, almost in all 50 states, it is mandated that you receive notification by a letter of your breast density. So your doctor does know about it. And it is, you know, their job or their part of their meeting with you to discuss that with you. But if they don't, you know, just know that you have that to discuss with them as well. You've also been notified. And so you can have that conversation with your doctor. And you can also have that conversation with me or one of my colleagues when you come into the breast center if you need to, or with Dr. K or with your OBGYN. You know, you can go in and say, can you explain this to me? Or what am I supposed to do about this? We're happy to meet with any patients that have questions.
It's a standard thing for me. If patients do have dense breasts with an abnormal mammogram or with a cancer diagnosis, I will go in and talk about it and add to it if need be. So I do discuss it, and I think most of the physicians do at this point.
Thank you.
Okay, so I'm going to kind of skip over some of the breast density. Okay, just so you see, this is what goes in the letter to you. So patients who received this in their mammogram letter, you've probably seen these words. It was, again, dictated by the state. So, okay, I know I've probably gone over my time. So real quick, breast MRI, isn't that better? Yeah, it is the best thing. It's the most sensitive to pick up breast cancers, but we also, again, pick up a lot of stuff that's not cancer. And then what do you do with it? You work it up, you have to get a biopsy, you have to follow it. It's also very expensive. It's very uncomfortable to the patient. If you think a mammogram is uncomfortable, this woman here on the picture on the left is in her breast MRI. She has to be like that for approximately 30 to 60 minutes, depending on where it's being done. It's just to stay still for that amount of time. We have to use contrast, which is an agent that goes through the IV. Which has some side effects, is pretty safe overall, but all these things have to be considered when we talk about what screen the general population with. So we really only use MRI for patients that are high risk or who those have already been diagnosed with the cancer, and we're looking to find other lesions if they meet certain criteria. And MRI is good with most cancers, but there's a small percentage of cancers that it does miss, which is why we have to still do the mammogram, and it's also expensive. And then one last thing I'm going to talk about just for, I guess, public service announcement is thermograms, because a lot of people have heard about this and or getting this. And I don't personally have an issue with you getting a thermogram as an adjuvant or health-based thing that you want to get with whatever provider is offering it to you, but do not consider it a screening test. And, we have patients who come in all the time who have not been getting mammograms, who say, I had this abnormal thermogram, and then we have to work it up. And this is what comes in the report. Like, I have cut this from an actual patient's report, and it says in their report, this does not directly detect or diagnose cancer. Thermal imaging does not replace mammography or any other diagnostic or screening examination. And there was this story in Good Morning America that some of you may have seen about this patient who was receiving thermograms and basically was told that it was screening her for breast cancer. She had a palpable mass. She got worked up this way. She essentially ignored this, not ignored it on purpose, but was told it was fine for 3 years. And by the time she finally got a proper workup done, she was stage 4 and was devastated. And so she did a whole thing on Nightline, and the FDA actually has since then tried to kind of follow up with some of these centers that are offering these as screening, because that's not what it's approved for. So just, again, I'm not saying don't do it for your own reasons or whatever you think is the benefit that you're getting out of it, but just know that it is not approved for screening for breast cancer. It does not replace a mammogram, and it may delay a detection of breast cancer that could be life-threatening. So, and I think I will end with that. Yeah, perfect. Okay, I'm gonna end with that.
Very good. Thank you so much, Dr. Singh. Great information. I do have a few questions that are in for either of you to answer. I have one here that says, how is genetic testing playing a factor in breast cancer awareness? Either Dr.
Yeah, I will be taking a little bit of that in my presentation, but go ahead, Evita, you can touch base on it.
No, you're better. I think you're better.
While it's okay, so I'll just I will answer that question as I go through my presentation. So
okay,
let me share screen. And
before you share the screen, I'm going to get a couple of more in, and then whoever asked that question, just tune in a little bit, and then Dr. K will get to that answer on down in your presentation. Is that right, Dr. K? I also have another one here that asks, are self-exams for breast cancer beneficial or encouraged to check for lumps?
I think so. I mean, I think I mentioned that. We definitely still see a lot of patients who feel their cancer first themselves because they notice that there's a change, especially in women who are under 40, because they're not getting screening mammography. And so they feel something that's different. So that's what's the reason that they're going to get the imaging done. And then we find the cancer. So I know there's some controversy among societies, but I really still think that, you know yourself best. And so it's still recommended as far as we're concerned, as far as the radiology societies are concerned.
So that's why it's called the breast awareness rather than a very, so like we said, yourself the best, and women are very tuned to their bodies because of the changes we have every cycle, every month. And, checking yourself, but you don't want to also spend a lot of time in there, because if you do, you work yourself up. And that is why there were some studies done whereby, they did clinical breast exams or self breast exams, and they found that those people had a lot more testing which was done, and their outcomes were all, not all, majority of them were benign. So that study said that it increased their imaging without really an anxiety. But having said that, between 2 mammograms, the whole year goes by, and your self-exam is the only thing which can bring you into us at an early time. So I would say it's called breast awareness. And yes, I would encourage people to check themselves, but you just have to spend like 5 minutes on each side during that time of your cycle when your breast is not as the most sensitive. And then that would be the time you would go for your mammogram as well. So I hope I've answered that question.
Very good, thank you. Someone else asked, are there any vitamins or supplements you can take to help prevent the risk of breast cancer?
It's mainly, I would say it's just the healthy lifestyle. There are a lot of supplements identified, but if I look at any particular research study or nutrition study, I can't pinpoint there is any one, thing which will prevent or heal the breast cancer. And, sometimes it's like just to say, I feel maybe strawberry can be the cure for the cancer, right? But it can take 100 years for that strawberry to cure your cancer. Well, you don't have that much time. The cancer will be progressing much faster. So to same answer, only supplements alone cannot help. Can they be an adjunct? Maybe. A lot of that is your placebo effect. A lot of it is the psychological effect of, feeling of a good feeling we get in doing that.
I'll say that, it's more like anecdotal, or there are some correlation studies, less so truly studied proper, medical trials. Some patients have, not about breast cancer, but like caffeine intake. And we have seen patients with like cysts and kind of fibrocystic pain who will come with ultrasound, and then they'll have tons of cysts, and then they'll cut. They were drinking like 5-6 cups of coffee a day. I mean, a lot of caffeine per day, not just 1 cup of coffee, but someone who's having a significant amount of caffeine intake per day, and then they cut that to 1 or none, and then there has, I've seen it where the cysts are less. So not necessarily cancer, but there must be something about what we do intake can affect our breasts. I don't know, Nafisa, if you've heard about just vitamin E with reducing kind of some of the fibrocystic pain or some of the cystic changes. But otherwise, yeah, there's no magic pill yet that we've identified. Overall, eat healthy, all your minerals and vitamins that you can get from natural sources. Try not to drink too much, try not to smoke, and stay active. And that seems to be the answer for all cancers. It's just keeping your body able to prevent as much of that disease as it can, because it does have a lot to do with your immunity. We're all making little cancers every single day, and every single day our bodies are keeping those at bay. And so, we just do the best we can. But yeah, overall general health is really the most important thing.
And, caffeine is not the only, coffee is not the only thing for caffeine. It's aerated drinks. It's any of your, the pops, your Coke, Diet Coke, and then chocolates. Chocolate has a lot of caffeine, but it's not, they say people can let ladies enjoy their caffeine a little bit, but everything in moderation, as we say. And again, the studies have shown a little bit of the placebo effect, but do I ask patients to take it? Yes, because if their pain is limiting their daily activity, then that is where they need to go into the caffeine. So having said that, I want to not miss this genetic testing playing a factor. So I can go ahead and share my screen.
Okay.
So I may overlap a little bit, and I'll try to, because Dr. Singh has already talked a little bit about these things, but again, thank you for the opportunity to present. And like I said, I'm the medical director and for the breast surgical services. And I also am the clerkship director. So I teach a lot to my residents as well as the medical students. It keeps me engaged and keeps me young. I always feel that people want to know are there guidelines, because with the pandemic now we are all aware of what the guidelines are and what the research is and what the data is. So I divide patients who have problems and then patients with problems and without problems. And that is where we say, assess your risk at the first. So your mutation history or your atypia, or which is your prior biopsy and family history. So that is the first thing I will ask about, is family history. And of course, increasing age. And then if that is the only thing that you have, we go into what screening tools we use, which Dr. Singh has already talked about. And if you're a person with problems, that would be, if you felt a lump, or there was some nipple change, or there is a discharge, or there is a breast pain. And I mainly will see the cancer diagnosis because Dr. Singh has done this excellent job of screening the people, and the biopsy is done, and I just get that cancer result. And then I can just go a little bit into the surgery part, the radiation, the chemo, and then how do we follow these patients who've had cancer treatments? So again, a little bit, so this is your, Angelina Jolie that we talked about. And I do have a link below. I don't have the time to go into it, but one of them is food as medicine. So, healthy lifestyle is very simple, but it's not easy. We all have a job to come to. So obviously we are not going to be eating healthy. But all these things have definitely shown, so there is food as medicine is one of the link down here, and it's by Dr. William Lee. And it's a YouTube video, you go into it. And, people get a lot anxious that I have not eaten healthy or I have done this. But honestly, even if you manage 50 to 60%, you are doing way better than the rest of, the world. And then, just ergonomics, family, whether it's music, art, whatever you enjoy, that is what kind of makes your meaningful life. And that is what is the best for prevention. I cannot meditate, but it seems meditation also has some, so obviously we are a lot of hyper personalities maybe,
Yeah.
but I do try to meditate if I can, because that is my growth. That is my meaningful life towards trying to do something which I am not very good at. And then, people say, oh, exercise, I don't have time to exercise. Well, there was again, another research article by the scientist. He lived with the tribal communities, and he said tribal people started laughing at me because I started running in the morning. And that's on your npr.org. It just says that, the scientist debunks theory of moving and sleep and how much sleep we need. And are we sitting today? Is sitting the next smoking? So there is all this. So go to the standard good websites, good research articles, and they will answer your questions on the risk and prevention. So coming back to, is your family risk and how does the genetics play into it? Well, genetics plays into everything. You are a type 1 diabetic, you have no choice. That's where it ends. Sugar ends for you over there. You have Angelina Jolie. She has an 80% lifetime risk of a breast cancer, and the rest of us are 10%. So we are all in this big bubble, and boy, am I glad I'm not Angelina Jolie, right? So that's where we are. So she obviously had to do a high, a scale surgery to remove as much of the breast tissue as she could to reduce her risk, which was lifetime 80% to 15%. So those are things which your surgeon will discuss with you after assessing your risk. So, again, Dr. Singh has already gone into it, but I just love my cartoons and I will show that. But moving forward, there is no online, mammogram. Please do not believe that. And yes, do not do thermograms as well. So this is the, four pedigree chart, which as a physician, I would kind of go into detail, or your geneticist would go into detail. And if you have 3 or multiple cancers in more than one generation, but mainly your first degree relatives, mainly younger people, then you meet criteria now to have a genetic test done, which is just a blood draw, but there is a lot of counseling which happens. Because why don't we just throw the net and test everybody, right? We have something called false positives. With the pandemic, everybody understands now what's a false positive. So we will find things which we don't know. And genetics is a very new field. A lot of people just do this 23andMe and they come to us. Well, 23andMe is not your standard for being BRCA negative either. So again, you have to meet with a physician to go into what is the latest evidence-based medicine, what is the data, and then get a genetic test done. And we can, with the genetic test, you have a strong evidence, and it can be a 30% risk with an ATM mutation. So there are at least 34 to 40 genetic mutations identified with variable risk factors, which are anywhere from 20 to 80%. So, just because you have a mutation doesn't mean, oh my God, you're a high risk for breast cancer. We have to see which mutation it is. We have to see those NCCN guidelines, which tells us how much is your risk, and then talk to you about it. I hope I've answered that question. So I won't go into this again, just the density of the breast playing there, but this patient has a cancer, and the MRI is better for this cancer diagnosis because there is a lot of dense tissue. So once there is a cancer, so screening MRI is, again, no cancer, but more than a 20% lifetime risk. And I do see high-risk patients with family history. And then we have the diagnostic MRI, which will be with cancers which are not seen mammographically or ill-defined. And MRI will just have it, will give us a better picture about it. But again, not everybody should have an MRI. So we are very, very particular about choosing the right patients, because it again increases a lot of false positives. Moving forward, again, a patient who felt a mass, but mammographically, we did not see anything. So she was only 40 years of age. And she said, I just had my mammogram. And then you do an ultrasound. So once a person points out to where their lump is, and I can feel that lump, we do an ultrasound and it shows up on the ultrasound. And then we do an MRI, and that cancer will show up on the MRI as well. So that is how we would use an MRI for a cancer diagnosis, which is not seen on mammogram. And then we would also, for a clinical assessment, we would see infection versus cancer. So we would see whether you have pain, whether it's just a solitary area of your breast, which is red. And that is just a simple treatment with antibiotics, needle drainage. And this would be a cancer diagnosis because this is painless. The person presents with a mass. And I'll just go to one more slide and then I'll wait for questions. So again, I need details from my patients. Is the discharge spontaneous? So you can see this lady, and this is not a person who said I had breast pain and I squeezed the nipple because I was hurting, and then I saw a discharge which is whitish or greenish. This is a person who just comes in and says, I see a stain on my bra, I see a stain on my nightgown. And that would be the pathologic nipple discharge, which I have to investigate further, but I should be able to also reproduce it in my assessment in the office. So I'll wait over here if there are any pertinent questions, and then I'll just have a 5 more minute slide and I will be done. So do we want to continue?
One question is, if breast cancer is in one breast, should both be removed as a precaution?
So the answer would be, depends on your family history and the extent of the tumor in your ipsilateral side, but a direct answer for me would be no. Unless you have a genetic mutation. So again, I have to assess how much is your risk for the opposite side. And if it is just the same average 5 to 7% over 10 to 15 years, our science, our guidelines say do not, it's like discourage removal of a normal breast if there is only a unilateral breast cancer without a very significant mutation or without a significant family history. So I hope that answers that question again in short.
Thank you.
All right. So, we are scaling back on older people because obviously increasing age is an increased risk of cancer. So we are limiting lymph node surgeries. We are limiting certain, radiation in patients who are over the age of 70. And, the other advances which we would have is we are very good with pain control for mastectomies. We do something like nipple sparing mastectomies, and we also do oncoplastic breast surgery. So we kind of look at the form and the shape that we can give back to the patient because that is, again, very significant once they have a good survival statistics. So just to go further, these are our guidelines, and you can see it is the choose wisely regimen. So we do not routinely aspirate every single cyst, which Dr. Singh had shown on her image. Even for infections, we don't have to incise and drain and anymore. We can do needle drainages sometimes, and we go from there. So we don't surgically excise those benign lumps and bumps. Again, there are criteria for surgery to be done. So I go over all those things when I see a patient in the office, and it's always a little of a discussion and answer every question and then move forward. Similarly, for surgery, we should not routinely, if the cancer is close to the margin, it's not always we have to do that surgery again. We don't advocate, like I said, specialized tumor gene testing in all breast cancers. We don't routinely order MRI in all breast cancers. We don't routinely perform double mastectomy in patients who have a single breast with cancer. And again, this is your answer to that question, is the choose wisely regimen. And we don't routinely excise a lot more lymph nodes either. Trying to move forward. So just a picture of 30 years, 40 years ago, we used to remove the muscle, and we started seeing that patients were not really very functional. So we started saving the muscle in the last 20, 25 years or 30 years. And the last 10 to 15 years, we can also do a nipple sparing mastectomy. So the patient's aesthetic outcome has become much better, and their functional outcome has become much better with the cancer aspects. And, these are some expansions which the plastic surgeon will do after the breast removal. So this is a patient classically with a single-sided breast cancer. She saved her opposite side. She probably needed a mastectomy over here. And that is the implant behind her, which is over here. And really, this cannot be squished, just like, and some of these are the same, which will go in augmentation as well. Or breast augmentation. These are some radiation aspects where we kind of put in this biosorb, which in a lumpectomy setting, and we kind of do some hidden scar techniques also. So the radiation doctors will kind of target radiation with breast saving surgery. These are some oncoplasty, again, hidden scars and a reduction with a lift, which can be done after a cancer diagnosis. So the idea of any cancer surgery is symmetry for the patient. So this is saving breast surgery, breast conservation, and it is along with the reduction because she probably had very large volume breast. Again, so I'll just go. So one size, the size doesn't matter. It's the fit which does. So this is what I was saying is based on tumor biology. It is what trumps your cancer, outcome. And the size of it can be small, but early stage, but you still may need chemotherapy. And it is the HER2 positives, the triple negatives, the lymph node positives. So those are the factors which kind of, lead us to chemotherapy. And the radiation will be given majority of the times with saving of the breast. But if you do mastectomy, then majority of the times that would not be needed. And again, over the ages of 65, 70, based on good tumor biology, we would not do radiation either. Sometimes we do chemotherapy first. So this lady had this big cancer over here. And it had although she's early stage breast cancer, we did give chemotherapy before surgery. And we could see on mammogram, like Dr. Singh would then look at it again, and the cancer has pretty much disappeared. And this patient will have a very good outcome with the surgery. And she saved her breast, she got radiation, and she's still doing fine after 5 years. Again, some bad pictures, but this is how helpful chemotherapy can be to kind of just get rid of or shrink the cancer down to be able to, for us to operate. And this lady is extremely functional. You can see her hand is all out and she's been radiated as well. So I think for COVID times, I'm thanking my societies to guide us. We could prioritize which patients needed surgery first, which could wait, which could go chemotherapy first. And that is what those guidelines helped us with. And we were really able to alleviate a lot of anxiety of these patients. Pretty much done. So cancer survivors, we only continue with mammograms. We consider MRI only if needed, and we educate patients again, survivor lifestyle modifications, bone health, quality of life, life expectancy. Dr. Singh has covered all of that. So these are my takeaways. You do your 3D mammography, you assess your risk and go for genetics. Breast awareness and exam is important. Refer to the breast surgeon for high risk monitoring. It's always a multidisciplinary setting for a cancer treatment aspect and for mutation carriers, and we have our guidelines for cancer. And, thank you. And I really would like to thank the patients who allowed and the societies and all of you for being here today to listen to us.
Absolutely. Thank you so much. Great presentation as well, Dr. K. I do have one question. It could have been answered along the way. I'm not sure. If diagnosed, should you seek a second opinion? Is there enough time? And what if the results are different each time?
So majority of the times, second opinion results are the same. Do we lose time? Well, not a lot. Again, it all depends on the biology of the tumor, but we have seen, typically, here's what I say to my patient. You should be satisfied with your questions being answered by the physician you have. It is always a trust-based relationship. And if you trust your physician to do the right thing, then you're all set. But if you do want another opinion, by all means, I think you should get it. And then you can, assess for yourself where you would like to go. So I hope that that's all I can say. Evita, you have anything to add? Oh, you're muted. You're muted.
We can come back on full screen, Dr. K. You can unshare.
Oh, I think you said it well with you should be completely comfortable with your care and know that you are getting, that you should be completely comfortable with your care and do what you think is best because you've sought out all the answers. But for the most part, breast cancer has been so unfortunately common and vast and studied, and there's been a lot of money put into it, and there's a lot of very clear guidelines on how it should be treated and managed. As Dr. K showed, the NCCN guidelines. As long as you are going to any of the major medical sites, especially in this area, we're very fortunate, we have so many, and you're seeing a surgeon who does breast. It doesn't have to be their only surgery that they do, but as a predominant portion of their practice, they do tons and tons of patients. If you can go to a place that has what's called a multidisciplinary tumor board, which we have, at Ascension, Beaumont has it, Ford has it. Every case that's a cancer gets presented there, discussed with a consortium of physicians. So even if you're only seeing Dr. K as your surgeon, other surgeons will chime in on what they think is the appropriate thing to do. If you're seeing Dr. Y as your oncologist, all the other oncologists will chime in and say, we're in agreement with this treatment. So you really should be getting like standard treatments across the country. Same for where you go for your mammogram. You should be going to a place that does a lot of mammograms, does a lot of biopsies, because then you're less likely to have an unnecessary workup, and you're more likely to have, standard managed care. I think in 2020, 2021, there's been a lot of discussion about who's the expert, and we, having trained in medicine, have trained for a very long time in our expertise. Like, I'm not here to talk to you about lymphoma. I'm here to talk to you about breast cancer, because that is what my expertise is in. And as a radiologist, I have some other expertise, but this is, my wheelhouse. I'm not here to talk about a lot of other stuff. Same with Dr. K. She's not here to talk to you about spine surgery. That's not her wheelhouse. So go to people who know what they're doing and feel comfortable with those answers. We do see a little bit of delay, I would say, sometimes patients wanting multiple opinions that can be then conflicting and confounding. But I know where we're at Ascension, our doctors do an excellent job, and they also do an excellent job of saying, your case is very unique and you need to go to University of Michigan. Otherwise, we're as good as any other place in the country when it comes to providing standard of care breast
So I agree, it's multidisciplinary setting. So we do every week, we would discuss every single cancer diagnosis that we physicians have seen, or the biopsy has been done at Ascension Providence. So you don't get just a single opinion, you do get the multidisciplinary setting opinion. And that is the key word. But again, this is a high volume center that we are at. So obviously we do have, and we also participate in research. So that is the place you are at. Having said that, I can say for sure that many other places will also, obviously, all the systems will really do a very, very good job.
Very good. You're providing us with phenomenal information. I'd like to let you know we're still monitoring you on Facebook. So if you have any questions that you would like to type in your comment section, I am watching there. Also, as well as Zoom, if you have questions, you can type them in the chat section, or you can unmute yourself and pose your question there.
I just wanted to add a comment till a question comes, or it's when we said about the numbers, life is a game of numbers, right? So, when we say that you have, it's like 5 cancers diagnosed out of 1,000 mammograms done, you have to let yourself believe that you will be the 995, you won't be the 5 which are diagnosed, right? Mm-hmm. So if you go to the casino and you have, or if you have a lottery and you say you have an 80% chance of winning, everybody will go get the lottery, right? So why don't you believe that you will be in the 80 to 85% who will not have the cancer and just get your mammogram done and go from there? We always it's a human mind which makes us believe that we will fall in the very, very small percentage. But really, we all drive, we all don't get into accidents every single day, and that's how life works.
Very good example. For those of you who are participating in our competition at the end, I call it competition, we're going to spin the wheel to see who is the winner of the gift card. I'd ask you to please at least type your first name and last initial. Some of you have numbers and some say iPad, so we can't identify who you are. You don't have to type your last name, but if you can at least type your first name while we're waiting on a few more questions. We're also going to do a post survey. You don't have to get the answers right, but the answers were provided within the discussion. So if you were listening attentively, you should get these 3 questions. They're the very same 3 as before. So I am going to put the questions up for you to take the survey once again and allow you a chance to at least type in your first name if you wish to be considered for the spin the wheel.
Real quick, I know while we're waiting for questions, COVID and breast. So a lot of patients have asked us recently about the COVID vaccine. So when you come into the breast center now to get your mammogram, you will be asked whether or not you've received the COVID vaccine. That is not because we have any judgment about who's had it and who hasn't. It's because it can affect your mammogram images. And so we need to know that so that we don't unnecessarily work you up for an issue. And that issue is not that it shows up fake cancers in the breast. I've had several patients say like, oh, well, is it going to give me, a cancer in my breast? It's that your immune system, most of us have gotten the COVID vaccine in our arm, and your immune system is responding to that side, and your arm drains into the same lymph nodes and into that portion of your breast as where a breast cancer would drain into. So when you get a breast cancer, the lymph nodes that get activated or can get affected are in the armpit and a little bit towards the chest and sometimes in the neck, but mostly in the armpit. And that is the same lymph node area that would get activated by your COVID vaccine. So when you get your mammogram, those lymph nodes may suddenly be enlarged, whether or not you can feel it, whether or not you're having pain, whether or not you've noticed it. We can see that sometimes on the mammogram. Before we all had mass vaccination, seeing a change in your lymph nodes would prompt us to either work up your mammogram more, because that could be an indication that you have a cancer that's hiding on that side. Or it could indicate that you have lupus or rheumatoid arthritis or something else. Or it could indicate that you would have lymphoma, which is another type of cancer. So it would prompt us to work you up. And now we have, millions of people with the COVID vaccine, and we're noticing this on the mammogram. So we get that information, which arm were you injected in, so that we don't necessarily have to work you up with the same suspicion. We can do a follow-up with just an ultrasound in maybe 6 weeks, or if it's very mild, we can just presume it's because of the vaccine. So I don't want patients to take any insult to that question when they come in, number one. Number two, I don't want patients to think that the COVID vaccine is going to change their mammogram or make their mammogram a problem. You absolutely can come in and get your mammogram done. We were having people kind of delay when they were coming in, but now it's so common and patients are getting their vaccines all different times. Just go ahead and keep your appointment. We'll figure it out after that. But it does not cause cancer in your breast, and it does not cause the cancer on your mammogram to be fake. It's not like that at all. It's because of the lymph nodes from the immune system.
Very good.
I do see a question, which is, if I have dense breasts and my sister had breast cancer, should I get genetic testing done? Well, your sister should get the genetic testing done. Depending on her age, if she meets criteria. If the person is older than 50 and there is no other family history, then your sister does not meet criteria to get genetic testing done unless there is other family history. And dense breast alone does not meet criteria to have genetic testing done either. So I would say, no, you don't need genetic testing. If your sister has done it, then yeah, and if there is something on your sister, then you get a letter asking you to get genetic testing done. But your risk does go higher than the average population because you have some added risk because of your sister's breast cancer and then the dense tissue as well. Hope I've answered that.
Absolutely. See, few more people are taking the poll questions. We'll just give you a few more seconds.
And while we are waiting, if people did want to know, one of the links that I had, which was food as medicine, it did say that actually chocolate is good for breast cancer. So it may have the caffeine, but chocolate is supposed to be good.
Yay!
For dark chocolate. So it's dark chocolate. It's not the chocolate.
Yeah.
Not the delicious milk chocolate.
Extra virgin olive oil. Those were the
Oh
two
my goodness.
So extra
Okay.
virgin olive oil is also good prevention for breast cancer. So I got those two take homes from the 1 hour presentation of Dr. by food as medicine.
Good. Yeah, I'm
Very
trying to
good.
think what else people ask. I guess from a biopsy perspective, just to let everyone know that nowadays we do everything minimally invasive. It's just a needle biopsy. Hardly anybody goes directly to surgery anymore without a needle biopsy. So just know that if you have to have a biopsy, or if that's something that, someone is going through, don't Google it. Talk to us first when you're told that you need one. It's a very, very minor procedure with just lidocaine, just like when you go to the dentist. It's a small needle, no stitches, no cutting. You drive yourself in, you drive yourself home. It's like a 10-minute procedure now. So things have really changed. I try to remind all patients of that when they say, oh, my mom had breast cancer, my grandma had breast cancer. It's not the same disease. I think Dr. K did a good job with the a little bit alarming pictures of how things were treated, 30 years ago. But it has come a long, long, long way. It is not the same diagnosis that women got, even 10 years ago. So much has changed. So
I agree.
It's so good to say, Dr. Singh, don't Google it, because we're going to Google it anyway.
Yeah,
but telling us don't Google it.
Well,
And
we
of course,
try to
we
give
always
you,
come up with the worst
yes,
results when we
yes.
Google.
Here's how I put it. Most patients who have good experiences don't go on Google to complain. It's the people who have like these rare, either that or are also having very sensitive issues that feel that they have to voice their opinions. I'm not saying that they're not valid opinions and that they don't need to be listened to, but that's not the predominant majority. Like 99% of people have no issues during a biopsy, have no issues, undergoing callbacks and all this other stuff. But as soon as you Google it, you get every worst case scenario. And that gives you unnecessary anxiety. When we're here to answer those questions for you and walk you through the process. That's why we have Gail. That's why we have, people in our department who are, Jennifer, and we have a lot of great techs. So just know that it's easy to go to the internet, but there are lots of people who dedicate their lives to this who are willing to talk to you instead. So
absolutely, we certainly respect that. Speaking of Gail, are you still there? We're going to do show everyone what they can win. We're going to spin the wheel in about 30 seconds. What do you have?
Okay,
What is it? I'm sorry, did I
yes.
catch you off guard? You ready?
No.
There we go. It's a beautiful
It is
card
with, thank you for participating.
and a $25 Visa gift card.
Yes.
So if we're ready, we're gonna look at that wheel right now. I'm so excited. This is such an exciting part for me. So bear with me. Let's see that wheel. We ready?
Yes.
the suspense. Oh, wow.
There it is. And some are identified by phone numbers, but you'll know who you are. And let's spin the wheel. And the winner is Nancy's iPad. Listen at the applause. Isn't that great? I wish we could have done that over and over again. If you are Nancy's iPad, please type your name and contact information in the chat directly to me. Me is Novi Public Library, I believe is how it's identified. Type your name and your contact information directly to me, and then we will see to it that you get your $25 Visa card.
Yes.
All right, we can stop sharing that screen.
Oh, did I not
Please
see-
do that now. I want to make sure that you do respond, because if you don't respond in like the next 30 seconds, we're going to have to spin the wheel again, because we want to make sure that we give that gift away. So Nancy's iPad is what it said. Please type your information in the chat directly to me. Novi Public Library is what I mean by me. Still waiting.
Is there a plan if you don't get that address?
If I don't get a contact information or a response that it's you, I think she's left the Zoom. Can we spin that wheel again? Is it all set to spin again? If so, please load it back in.
Uh-oh.
I'm sorry, Nancy. We're going to spin it one more time.
I have to say, this is a very nifty website there.
Isn't it? I love it. Laura
Yay.
Anderson. We share the same last name, but it is not my relative. Trust me. If you are here, Laura, please type your name in the chat directly to me and your email address or contact information. Laura Anderson. You still there? Click participants. We're going to narrow it down. It'll be easy to. Oh, I got Laura. We have a winner. Okay. That was great. Okay. Any closing comments? We're a little bit over, but it was certainly worth it. Any closing comments from the doctors, and then.
I mean, I think I gave my spiel already about come
Okay.
to us, but yeah, just everyone take care of yourself. You know, women have to do it first. We always forget. Stay healthy, stay well. You know, get your mammogram,
Stay
get your
kind.
COVID vaccine. No, yeah, stay kind. We're in a tough situation this year, but people are coming back in. You know, we had a lull. We shut down during the whole pandemic craziness, and it's safe now. Come back in. There's, you know, probably the safest place to be right now is in the hospital because everyone's masked. so don't feel nervous to come in to get your mammogram, and we'll take good care of you.
Very good. Dr. Kay?
Really, just the same things. These are random events, and this is all we can do to have a chance to find these cancers earlier. And healthy lifestyle, the best we can. It's again preferences, but the best you can do to have this meaningful life. And we are blessed if we are healthy and we are gainfully employed or just well. Thank you.
Very good. Thank you, Dr. Kay. Thank you, Dr. Singh. A very great presentation. I'd like to thank Ascension Providence Hospital and the American Cancer Society, along with the Novi Public Library. It is our mission to inspire, inform, and include, and we hope you were inspired to check on yourself. Don't fear, don't panic. Do what's good for you to take care of yourself. Coming up November the 9th, we will have another For the Health of It program, and this will focus on lung cancer. Once again, it's November the 9th at 7 p.m. And then mental health and nutrition will be December 7th. You can log on to our website, novilibrary.org, to register for the program. You can also call us and register as well. We hope you can. We will see you then. It will take place on Zoom as well as Facebook Live. Thank you, everyone, for joining us this evening, and have a good night.
Thanks.
Thank you.
Thank you.
Thank you.